Hello everyone, welcome to the Race Academy webinar series number 31. What an exciting year it's been. I can't believe we're halfway through 2023. And as everyone knows, we have our world-renowned professor back with us today on a topic that's close to my heart, because we do hear this a lot in the lab. And recently we had a customer contact us saying the patient believed they were allergic to a zirconia in one of our monolithic opalite restorations. So I've been waiting to hear with anxious words of what Professor Stubbs will be with us today. So I won't harp too much longer. Firstly, I'd like to say congratulations to everyone on board today: Australia, New Zealand, the US, Malaysia, and UK. So again, we've got a spread across the globe. Great to have you all with us. We do appreciate you taking the time to join us to learn what Professor Michael Stubbs is going to be talking about today. Doctor, I think I am allergic to this new crown or denture that you've put in my mouth. What do we do when this happens? Please, we do encourage questions. We'll be leaving them until the end, and I will be asking Professor Stubbs or trying to do with them myself. But put your questions down the bottom and I will address those at the end. But to no further ado, Michael, how are you today?
Very well, thank you. Thanks very much for inviting me to come along and speak.
Look, it's a real pleasure. You're obviously one of our most requested speakers, so I do appreciate your time. We've got some awesome topics coming up towards the end of the year with you as well, I believe. But with no further ado, Matt, over to you. How do we do with allergic topics?
Thank you very much, Matt. It's an interesting topic. I thought of it because, like, sometimes I get patients referred to me from their colleagues that would say things like, I've done a set of 6 veneers and the patient feels really uncomfortable and they're suggesting I could be allergic, or they could be allergic to the material. So I'd like to talk about this just from a current science perspective anyway. So one of the things we know is true allergies, where you get the absolute swelling, we call angioedema, where you get this predominant swelling of the lips particularly, but can be the tongue, which is obviously more serious, are fortunately less common. Lichenoid, which I'll explain in a moment, is actually more common. And so what that really means is you can see this photograph here of a patient who has intense red gingiva. And you can see actually it goes from the unattached gingival margins full thickness. So when you look at these, when I look at these, the first thing I think about is it's either something locally causing a generalized reaction, or it could be something systemic causing a generalized reaction. And you'll see down the bottom here, it says plasma cell gingivitis. So what does that really mean? We don't normally see it that commonly, but I've had a couple of cases in my career, because we don't see it so much in the Western world. In Asia, where there's more, say, cinnamon and some of the flavorings in toothpaste can be a classic trigger for this. And the patient will present with incredible intense erythema, redness of the gingiva. And the treatment is twofold. One is obviously trying to work out what the trigger is. So I always suggest, when you see something like this, ask the patient if they've tried perhaps or started a new toothpaste. Have they been using a whitening product? Something along the lines of that first. And also a biopsy is what corroborated the diagnosis. And it very quickly rules out lots of other sinister conditions. So this is an example I've put in just for the benefit of I suppose you could call an inflammatory condition or change that's brought on directly by a trigger. In this case, it was toothpaste oriented. And you can see on the left-hand side of this slide, there's the classic white and red patination of the buccal mucosa. And this was biopsied, and it was confirmed to be what we call oral lichenoid reaction or oral lichen planus. So the reason I found this article, which I thought was really interesting, so these photos are from the article listed below as a reference, is they replaced the restorations, and obviously in that situation, the condition resolved. Now, I have to say, from my experience, I think it's probably fair to say in general terms too, that degree of miraculous improvement by changing a multitude of fillings was probably in many ways based on the biopsy result, but also it was a patient agreeing to have their fillings replaced, because it gets tricky. you know yourself, you've got patients who have sound, even if they're amalgam restorations. Amalgams are not bad. It's just that they're not commonly done these days. And often one of the most common types of, if you like, reactions that we loosely called allergy, called lichenoid, is typically from amalgams, but it's not the only reason. So this purpose of me showing you this is really to say that if you can nail it and you get it right, you can see the dramatic improvement. And that was actually based on changing the restorations in this particular article. This is one not one of my patients. I searched the web wide and low, and I was looking for examples of lip swelling. Now, on the left-hand side, this lady clearly doesn't look very happy, very puffy, swollen lips. And on the right side, that's what she looked like before. So again, you think allergy. Now, when we think allergies like this is called angioedema. Angioedema is a condition where there are two types, but one of the most common one is the acquired form, where something triggers the IgE, immunoglobulin E, and boom, they get the swelling. You can see this in drug reactions too. And one thing on the side, just to mention too, if you have a patient, let's say, who presents with swelling in their lips or their tongue, don't automatically jump to the conclusion it's their dental work. It may actually be a medication they're on. And some of the angiotensin converting enzyme, they call it ACE inhibitor, blood pressure tablets, can actually do it. And sometimes patients be on the drug for 20 years, and all of a sudden they start getting the swelling. And as I indicated earlier, metals particularly, so amalgam's well known to be a trigger for these type of reactions. And again, you can see on the bottom photograph of this slide, this actually quite intense white change. Again, it was biopsy. And the reason is, don't assume just because it's adjacent to the tooth that it's got to be to do with the tooth. It could have been what we call dysplasia, abnormal cells. So it was biopsy, and it came back saying it was a lichenoid / oral lichen planus. Now, you might say, why does he keep saying that? Well, it's because when you look down the microscope, you can't always differentiate the two. Lichen planus is where we don't know why people have the condition. Lichenoid is where we can attribute a cause particularly to it. And one of the obvious things is if you get rid of the cause, it disappears. Like that previous slide with the photographs of before and after changing the dental filling materials. You can see I've also made notes here, including gold, palladium, nickel, and chrome. Now, a lot of crowns these days and bridges are using the non-precious metals because gold is really expensive. And they're also looking for a metal which gives the crown or the bridge robustness, durability, stability, and stiffness. And sometimes in some patients, they can get reactions to these metals, particularly palladium. And again, I'll go into that in a moment. And so when we talk about this lichenoid reaction, and again, I'm referring to this terminology, if you don't mind me putting my oral pathology hat on for a moment, you can see here, this is the surface layer of the mucosa. So this is what we call keratinocytes. This is the corneum or keratinized layer. These are the keratinocytes. And you can see this purple dot band. This is a mixture of T cells and histiocytes. So lichen planus lichenoid has a classic appearance. The difference is in these lichenoid reactions, we often will see a higher number of plasma cells, which are more induced by localized production of antibodies. That's what plasma cells do. And also, you see the arrow, that's actually where the collection of these immune cells are around blood vessels. So the rationale for me explaining this is just that when I keep using the terminology, I'm talking about an autoimmune response by a trigger, which may be a dental material. It could be a medication. And in the end, the immune system is so good at protecting us, it actually attacks the host. And so you start to see these changes. And in the typical example of dental material related changes, one of the things that I gathered from doing a literature review myself on this topic to do the presentation was they all say the same. Look at the tissue, make sure, is there any evidence of tissue changes before we start ruling allergy into the conversation when it may not be. So that's what we call a lichenoid reaction. And as I said, amalgams have reputation, although not common. So again, you can have amalgams in the mouth. They're quite safe. They're quite stable. They're inert materials. You get little pigment. You know how you get little tiny fragments of the amalgam in the gum? It's called an amalgam tattoo. Again, they're quite safe. Long-term, no demonstration of any effects on the human health. But in some people, you can get this autoimmune response. And so hence treatment was replacing the fillings. And the interesting thing about amalgam-induced lichenoid reactions, which I'll just quickly scroll back, just for the benefit of everybody here, is that sometimes, if I may suggest, if you're not sure if it's an amalgam, let's imagine a patient has 3 or 4 teeth amalgam restorations. May I suggest, firstly, polish the amalgams first, because it's interesting. Sometimes there is a concept where it may be the oxidation products on the surface, the corrosion might be the trigger. And also, in fact, the bacterial colonization on the surface of the restoration inducing the reaction. So polishing the restoration is a very non-invasive way of doing it. And if you're looking at this type of approach, you might consider maybe replacing 1 or 2 fillings and then re-evaluating if there's any changes in the tissue rather than doing a complete full mouth rehab on the assumption that the changes are related to the dental material, the fillings. And when we look at that too, it's pretty hard because if you get these heavily filled teeth like this, when you do the restoration replacement, this person's going to lose more tooth structure. What's the strongest part of any restoration? The tooth that remains. So, you want to be avoiding clearly pulpal involvement. And so the judgment call generally is the conversation you have with the patient. And in general consensus is you talk about the advantages and disadvantages of leaving the fillings in the mouth, monitoring, or actually replacing them. And the patient obviously has contribution to that conversation because they're going to pay for the work. If the lesion's painful, like here we've got a fantastic photograph here of the tongue. This was lichen planus, in fact, and you see the arrows highlighting this area of change. Then if the assertion is that it is related to a dental material, changing the filling material, changing the material being used in approximation of where the tissue changes is quite a reasonable assumption. But again, discussion with the dentist and the patient is imperative. And one of the things that's really interesting too, I mean, like in oral medicine, one of the things we do is we don't often refer a patient off for a formal scratch test. Now, you can see the photograph on the top right-hand side of the slide. Each number denotes a different type of stimuli trigger. So it could be food preservatives, it could be toothpaste components, dental materials, common filler particles in medications, quite an exorbitant number of tests. And the benefit of this was obviously to see if they get a reaction on the skin, to see if you could attribute that as a cause for the reaction in the mouth. Now, this, like any good idea, there's always some negatives. The negative number one is that the skin reaction doesn't always mean that you're going to get a reaction in the mouth. So the mucosal response to a material may be very different. In other words, not as much, if not at all, compared to the skin test. And the second thing is when you look at these, when they're peeled off, and they look at the red spots, they look at the degrees of variation of intense redness in each stimuli, then the colleague doing the testing has to be the one that makes the judgment. Yes, it's a reaction. No, it's not a reaction. So it's not an absolute, but I suppose what I would like to do and say to you is that if you had a patient, let's say, where you were concerned about an allergy in a material, it could be the cement that you're using to seed a crown, it could be a metal that you're using in non-precious metal, particularly in the mouth, then there is always this as an option to validate before you start replacing the materials. Obviously, if someone who's treated has had no problems at all, they get a set of 6 veneers and suddenly their lip swells up, I think it's a fair call. You could link the association just based on time. But the complexity of this is more about what happens if the patient has the material replaced and they've still got the condition. And that's a hard one. And I'm not sitting here saying it's easy either. It is hard. And so if we're lucky enough to get, well, when I say lucky, if the patient gets a response where they get blistering on the skin as well, you know you've got something that the patient is potentially allergic or is allergic to, and you can work backwards from there. The non-precious metals, this is a beautiful image here of a bridge. Again, it's interesting because palladium and platinum are more commonly used in these materials for these restorations because of their resilience and their strength. And as I mentioned a moment ago, the cost of the gold itself has gone up, incredibly expensive. And palladium, interestingly enough, has a chemical resemblance to nickel. So you could say, for argument's sake, that if a patient is allergic to nickel, they may have a reaction to the palladium. And more interestingly enough, it says here that this publication, yes, it's 1995, but old studies are still good. And it just says here, they showed that highly sensitive nickel allergy patients reacted to the palladium on patch testing 4 times more often than people that had a nickel allergy where they got a low response. So the take home is that if you're using the non-precious metals and the patient starts to get localized, particularly reactive changes, I think the first thing has got to be a time frame. You've got to think about when it was done and when you're looking at the patient. So it's 1 week, 2 weeks, 4 weeks, that type of thing. And second, understanding that if someone's got a nickel allergy, they may be related, may react, to the palladium and platinum in the, particularly palladium anyway, the non-precious metal and what you're choosing. So it might influence your selection. You might go for zirconia bridge rather than a metal framed one. And in this case here, they show that this, if you get evidence of skin, they call them granulomas, it's just an immune response type to the metal, the probability of a palladium allergy is quite strong. So there's, in my opinion, one take home that you might like to use for your own reference in your own patients. You can see here on the crown, rather nice VMK. There's obviously a labile metal collar there exposed. Look at the gingival reaction. Now, again, you could look at that, and if you're the one that's put the crown on, and suddenly there's a dramatic deterioration in the gingival health localized to that area, you might say first, is it retraction cord that's caused trauma? Is that what I'm looking at? Or is it something to do with the hygiene of the gingival region and the patient care? Or is it actually an allergy? And then consideration of replacing the crown. I always err on the cautious side first before I commit to say to any patient, get your work redone, because there is a big cost involved, as you know, and also you want to get it right. I thought nickel was interesting too. We know that about 1 in 5 women are allergic to nickel, and I think a lot of that may have to do with jewelry, like earrings and things, piercings. And it's not so common now in piercings, but certainly was quite some time ago. And so nickel's not really used in dental materials generally, but there are some interesting ones we do use in dentistry that have nickel in it. And the stainless steel crowns I thought was interesting. It's very low contaminant. And so most children, interesting enough, don't seem to get the allergy reactions. But again, if you put a stainless steel crown on a tooth in a patient, and again, you're talking about a localized reaction immediately around that where the stainless steel crown was placed, there's a possibility it could be an allergy. And I thought that was rather interesting too, because we use NiTi files, endophiles, which actually have a very low risk. But the other thing also, the NiTi orthodontic wires, because the NiTi wires, whether it be for endophiles or for arch wires, it gives that degree of toughness, but also that flexibility. So when you're putting your file in the canal, you don't want it to fracture. Now that as I'll show you in a moment, the suggestion that using NiTi endophiles in a nickel allergic patient is very unlikely to cause a problem. They even suggest that the NiTi wire, orthodontic band wires, have a low risk in the mouth. But nonetheless, if you had a patient, you might consider an alternative type of metal composition of what you're using in the mouth. So it's interesting too here, stainless steel dental hand and rotary instruments. So one of the things they suggested was in this article is actually we use rubber dam anyway, so we isolate the soft tissues away from those particular metal tools that we're using to minimise any risk anyway. And it's interesting here, stainless steel crowns consist of a range of between 7 and 22% nickel. And to be candid, I didn't know that until I started doing this literature review. So that was interesting from my point of view. And the nickel ions are released into the saliva over the stainless steel crowns of orthodontic appliances over time. Again, not everyone gets a reaction to it, but it's something just to consider if in fact you've done the work and the patient starts to complain that they're noticing their irritation in their tissues. And here we can see the NiTi files that are being used, the rotary type endo files, because of that flexibility and resistance to fracture when it bends inside the tooth. And the interesting thing here too, I thought, was oral mucosa has a much higher threshold to a reaction than skin, well tolerated in most patients. So even if you are using these type of metals, the chances of an allergy reaction from them in the mouth is pretty small, because the oral mucosa seems to have a much more better tolerance to them than the skin does. So when you do the scratch testing, like I just showed you the photograph previously of that patient, and all those multiple little stimuli on their back, which, by the way, if anyone watching this has ever had a scratch test, they'll know what I'm about to say. Most times, certainly here in the patients I refer off, and I don't see many of, it's a pretty involved process. On a Monday, you get the scratch test. On the Wednesday, you go back and they have a look. And then on the Friday, you go back and you're not allowed to shower for the 5 days. So, winter, probably a preferable time than summer to have this done. And again, look, this is the NiTi ortho wires. And again, you can see here, should be replaced with stainless steel wires. That was what some of the suggestions were in these appropriate referenced articles. But again, you use your own judgment. I think if you have a patient that says I'm allergic to nickel, you probably would be thinking straight up, look, you probably might consider an alternative. If you have a patient that doesn't know they're allergic to nickel, and in fairness, you probably may not, and the patient probably doesn't know either, then you just maintain and use what you normally do, which is your NiTi wires in the case of orthodontics. And cobalt chrome, now I apologise for the poor quality of this photo, but you can see clearly the major connector there. And when in the literature I reviewed, certainly one of the things it talks about often is you want to see direct changes of the oral mucosa beneath the denture. And it's interesting that cobalt chrome is quite an inert metal, and generally speaking, and so they're quite rare to have an allergy in the mouth. You're more likely to get something more from an acrylic-based denture than you are from a chrome cobalt. But again, you have a look. Now, we would call this a couple of scenarios. Imagine if I saw this patient and they had the denture in the mouth for 1, 2, 3, 4 years. What's one of the things you might look at and think about in your differential diagnosis? Denture stomatitis. Do they wear it to bed at night time? Is there yeast or candidosis? Doing a swab. If the patient actually has a new denture replaced, and then they start to get these changes, and they can be quite burning and stinging sensations, you would have to entertain, I would suggest, a possibility of a material allergy. And here's a beauty, maxillary edentulous region in the palate, and look at the intense redness, absolute demarcation of the full upper denture. So what I thought was interesting too was the recommendation was, firstly, number one, if there is a suspected allergy based on a denture, have the denture removed for a few days and it should improve. Second, if it's usually going to happen on a replacement denture. So, you've got a patient who's had a full upper, say full for 20 years. You replace the dentures and suddenly they've got these tissue changes, but they didn't get the same response in the old ones. You have to start thinking, well, is it something to do obviously with the material? Is it the way, perhaps, what material they used? The methyl methacrylate is considered to be one of the triggers for this type of reaction. And we call these changes lichenoid reactions because they're absolute intense autoimmune reaction to the material or the contents of one of the components of the material. And again, before we jump to conclusions, there'd be a couple of things I would recommend. Obviously, one, how long have they had the new denture for? 2, is there candidosis? Have you done a swab? And 3, do a biopsy. Confirm that it's actually a lichenoid or autoimmune response first before you start thinking about transferring the patient, saying, right, I better get a new denture made again, etc., etc. Because again, it all has costs. And in this particular one too, you can see that in those cases where you might put a tissue conditioner. Now, I appreciate this is probably old-fashioned, but then, hey, I'm old-fashioned too. But, you know, putting tissue conditioner on the fitting circuit of the full upper does separate the material. And also you'd have to ask the question, when this reaction, when you're looking at it, is it something, a new denture? Because they seem to be the more common reason why a patient may go from one denture to the other and suddenly get a reaction. And always entertain the idea too, it may not be anything to do with allergy. So I think one of the take-homes I hope that you might be deriving from the presentation is make sure that whatever you determine as far as an allergy reaction goes, have a look to see if you get adjacent tissue reactions, because that gives you some insight in it's possibly an allergy reaction, possibly. And a biopsy where you can get some validation of the type of reaction that we're looking at. Now, this one was taken, this is an interesting article actually, and the reason I put it in, this was a patient who had a cold cured type temporary crown made. And in effect, they got this massive erythematous change within 24 hours, burning, stinging sensation. And then the temporary crown was removed and they were given a steroid mouthwash, and ultimately over a few days, the condition improved. And the determination was they reacted to the methyl methacrylate monomer. So again, for me, the take home was cold cure acrylics. You're more likely, if you've got residual monomer, maybe to get a skin reaction in the mouth than you are the processed acrylics, which we typically see in dentures. Be interesting to see if because the 3D printed dentures that Race are doing too, I'd be interesting to see if we do see these kind of reactions, because it's different material. And I think that, again, it's the correlation of the time of when the treatment was done and the reaction that's occurred. I thought this was interesting too, because we all know titanium implants. And, you know, in the last 10 years, a lot of articles talk a little bit about there is a possibility that there's an allergy to the titanium. There's a possibility that it's underestimated, therefore it's not published enough. But again, all I can say to you folks is if you see adjacent tissue reactions, that gives you more insight into a possibility of reaction. And in this particular photograph taken from this article, it showed rather clearly this granulomatous type tissue reaction adjacent to where the implant was placed in this area of the healing abutment. So again, I wouldn't be jumping to the conclusion that the patients had an allergy to titanium, but you wouldn't certainly want to do a biopsy to actually get a much better understanding of the tissue reaction. And this particular article also talked a little bit about changing patients who did have an allergy to the titanium implant to the zirconia ones, because they're much more inert as far as biological reaction. So again, I'm not a prosthodontist, I'm an oral medicine specialist, but I thought that was rather interesting to suggest transferring it to a zirconia one if in fact it is an allergy to the titanium. Again, I have to say in the literature, it's not commonly reported. It's often in earlier papers said that it's virtually inert, and it may well still be. But you do get cases where people do get reactions to these materials, and it's something that can be a little bit unpredictable, which makes our job a little bit more interesting and perhaps a bit more demanding. Impression materials, you know, the silicone-based materials seem to be the best alternative. Certainly that was published in 2015. One of the advantages of impression materials, if you're not scanning, is the fact that the material doesn't stay long in the mouth. So, you know, 2-3 minutes. And so the likelihood of a reaction to the material is pretty small compared to, say, something fixed in the mouth or a denture, or it's sitting in the mouth 18 hours a day. So I suppose as a dentist, the real take home here is, what do we do? You know, like a patient comes in that says they're allergic to what we just did. I suppose one is the answer is not that easy, but here's a photograph of a tongue, and there was a tissue change here, which we would call lichenoid or lichen planus type reaction. But again, this was biopsy. We want to rule out dysplasia, abnormal cell changes, and you also want to make sure what you're looking at is actually what you think it is. So again, biopsy is a good move. And obviously photographic evidence is great, very objective, so you can record the size of its changing in growth. And as I mentioned a moment ago, just because you've done some work and they get a reaction, don't assume necessarily straight away it's linked. It might be something incidental that's occurred at the same time, but always assume in the back of your mind, is it an allergy? And again, it comes back to, in my opinion, biopsy the tissue to actually get some validation before you remove dental work. And, you know, like this is a good example here, nice central incisor, the arrow is pointing to this intense gingival area. So first, I suppose you'd be thinking, okay, is it a reaction to the crown? Is it because of the loss of the biological space because the margins were cut below the CJ? And so now you've got chronically inflamed gingiva. Is it also related to perhaps a hygiene issue? So again, their considerations before you replace the crown. And again, the conversation always with the patient, replacing the crown or trying a few other approaches. Again, it's not easy. And the reason I was keen to do this topic was because I know it's not easy. And when patients get referred to someone like us, oral medicine, it's not easy for us either, because we realise that when we make recommendations for replacing work, we are trying to be as focused, evidence-based as possible to make the right decision for the patient. And also recognising that if you are going to have a patient where they've got these lichenoid changes, like I showed in the earlier photographs of the presentation, realising that even though there is a very low premalignant change, particularly lichen planus, which is idiopathic, unknown cause, if you've got a patient with these changes in the mucosa and the patient decides, look, had a biopsy, it comes back oral lichen planus / lichenoid reaction, and then they say, look, I don't want the work in place, I'm happy just to leave it. Really to have the patient monitored like any person would be for lichen planus is appropriate because of the low premalignant risk to squamous cell carcinoma. So that means in real terms, in Europe, the European protocol suggests 2.7 people out of 100 with lichen planus biopsy in the mouth diagnosed, they can become a skin cancer. It's probably a lot less than that. But you do have to go through that process of following the patient up as part of your normal assessment of the patient to make sure that if they do have these changes, you want to get an idea it's getting worse, and also appropriate management. And usually, most times, patients are referred to a prosthodontist for an opinion, certainly an oral medicine specialist or an allergist. And by the way, as dentists, we can refer our patients to allergists. We can also refer them to ear, nose and throat colleagues, and the patient gets Medicare entitlement. And this was the photograph of that one with all those patches. And I thought I'd save the image of the back afterwards, but look at the intense reactions. So this person obviously had a lot of reactions to certain stimuli and not much to others. So that's what happens on day 3 when they take the patches off to see what the response is. And lastly, when in doubt, always feel free to reach out, and you can contact your other colleagues, oral medicine colleague, perhaps prosthodontist is always a good choice, particularly when you're talking about replacing work, particularly when you're talking about reconstructing, let's say, a bridge or something, you're looking for alternatives in materials. And more importantly, as I said earlier, always feel free, you can ask an allergist as well. So on that note, I'd love to welcome any questions that you may have.
Thank you, Michael. Very, very interesting. So I guess for that customer of mine who contacted me saying their patient was allergic to the zirconia crown, I'd recommend the next steps for dermatology testing, right?
Well, at least, yeah, you'd want to have some photographs to see if there's any tissue reactions first, because I think that's the important bit, because that's what I gather very much from the reading in the last 15 years of some of the articles published. They all talk about evidence of changes in the tissue. So you want to make sure you get the evidence before you replace the restoration. Now, you know that photo I had with the swollen lip? I mean, that's a bit different. I think in fairness, if you can link it between having something done and suddenly getting a swollen lip, I think it's quite reasonable to replace it pretty quick. But for these other conditions where they are more chronic in nature, and you're not sure, always look for tissue changes and a biopsy, ideally, before maybe replacing the work.
Okay. We have a question here. What happens when the patient is allergic to an implant?
Yeah, I know. It's a tricky one, isn't it? Now, I don't have the answers to that. I can only share with you the references that I've provided in the talk, because in the, I'll just, if I may, I'll just scroll back. This particular article in 2021 was actually quite interesting, and it talks a little bit about the correlation. Again, you'd be wanting to see tissue changes. What interested me about this particular review article, literature review on titanium allergy, was they say the implants may present with persisting low-level pain from the material in the bone. Now, again, if you don't mind me saying, I'd be wanting radiographs to demonstrate changes in the bone around the implant before I took the implants out. And again, it's a big investment on the patient's part to have them put in. So you're having them taken out on an off chance it could be allergic. It's a pretty tough call. And what I would advise is certainly have a chat to perhaps a local periodontist, your local oral maxillofacial surgeon for some advice as well, because they're the type of colleagues that put in implants often a lot. And as a result of that, you know, just their clinical wisdom might be helpful for you as well.
Okay, that makes a lot of sense, mate. Another question here. If you can't solve it, at what point do you say, hey, Crown, I think I am allergic to this patient?
Yeah, the dentist is allergic to the patient.
Well, I think there's someone's trying to make a point. When can you to say that I can't deal with the patient, or do they just outsource it to a specialist, I guess?
I would suggest that, you know, and I think one of my first calls would definitely be even to a prosthodontist. You know, I mean, I realise one of the obvious things is, I'll give you a scenario, and this is just a clinical scenario, but, you know, you do a crown, let's say a full gold, and then there's a tissue reaction, and you say, yeah, I reckon it could be related. So you replace it with, let's say, your zirconia crown or your Empress or something like that, and there's still persistent changes. Then you might then say, right, fair enough, I'm going to get some advice on this. Again, you'd be wanting to see evidence, I think, of the changes that have occurred based on the photographs you have before you did the procedure, and then so you've got some evidence of the tissues. And I suppose there's an argument here to take photography as a routine. I mean, like oral medicine people do it all the time, because that's what we look at, the tissues. But, you know, having photographs pre-treatment, post-treatment, you can look at the soft tissue changes to see if there's any change. And if there was, that starts to indicate there could be an allergy. But it is a hard call, and I'm certainly understanding of that question, because it's not easy.
Yeah, it does sound quite involved. Professor Stubbs, what is the effect of adhesive cements containing polyacrylic acid, for example, replacing metal fillings or crowns with ceramic and then using potentially allergenic cements?
Well, again, you know, interesting enough, from what I read, yeah, the glass ionomer type base seem to have the lowest type of reaction, a tissue reaction to them. Obviously, you do it under rubber dam, so you try to minimise the process of bonding and cement excess and everything outside in the mouth by rubber dam isolation. And again, I'd advise that in colleagues that aren't sure, you'd always look at the material safety data sheets, which do exist for every material you use. And you can have a look, and they do talk about allergy reactions, and they do talk about the incidence of them. That cold cure acrylic one that I showed you, that case, the methyl methacrylate monomer, from what I can gather, and again, I'm not a prosthodontist, but I can gather is that seems to be a common trigger in these ones that do get the allergies. It's more the cold cure acrylic rather than the appropriately processed full dentures, where they're literally heat cured, and so you eliminate the residual monomer.
Yeah, great points, and I'll touch on the benefits of the printed dentures in those regards in a moment. Could a virus have anything to do with gingival flare?
A virus?
Yeah.
I suppose the answer would be, it depends if it's generalized versus localized. So there is a condition which is it's not necessarily virally caused, but linear gingival erythema is where the unattached margins are bright red. And that, again, usually can be caused not just because of an allergy reaction, it can occur in some viral conditions.
Wow.
One of them being HIV. This is more before the development of appropriate treatment, heart therapy it's called, but that was one of the things we used to see years ago. So I suppose if I could take from that question, the answer would be the entertaining of other causes rather than just blaming the material is a reasonable assumption first before you replace it.
Right. Look, I want to touch base on when, as a young Crown and Bridge metal worker myself, working on those high palladium based alloys of the semi-precious porcelain fused to metal, Michael, I used to get a red rash on my arm at the end of the day, and which I didn't get when I was working with the precious full gold crown. So it must have been, I figured out an allergic reaction to the palladium. The second I used to wrap my arm before I worked, I didn't see the problem. So yeah, they can be quite, even a short dose or a 2-hour burst on these alloys can really see a noticeable change. And I think that's why a lot of the industry is gravitating towards metal-free solutions. I wanted to let everyone know we have an enormous amount of different products within the lab, so you can lean on the plethora of materials and material science that we have. For Crown and Bridge, there's lithium disilicate, zirconia alloys in the way of gold, palladium, platinum, cobalt chrome's also popular for alloy crowns. Polymethyl methacrylates that don't have monomer, that are fully milled. In our removable departments, we have acrylics, PMMAs, printed resins, cobalt chrome. So if you do have patients and you can locate or understand where the problem lies, Michael, the lab is well positioned to support you in finding products that would be more suited.
That's good advice. And the other thing too is what was interesting was more healthcare workers and people that work in labs and with the dental materials are more likely to get allergy reactions just from sensitization because they're exposed to it. So good ventilation and all the rest that you guys have. It's really interesting because they often refer to that. They often refer to the fact that the people, the healthcare workers involved in making of the dentures and the crowns and all the rest that go with it, the chemical exposure, the sensitization, they're more likely to have an allergy reaction than a patient.
Yes, interesting, Michael. We've come to the end of our time here, but as I always do, I'm having troubles finding words myself today, so I'm going to throw it over to you. Throw you under the bus. If there's anything you want to leave us with in regards to this, or how our clinicians can best support their patients with these needs.
Look, I think if I may summarise, I think the first thing is there's clearly a time element from the time the restoration was done and the changes that are reported. Secondly, there'd have to be, in my view, in most cases seem to come through that there's tissue changes which support a reaction. Thirdly is seek advice, and certainly you're right about the laboratories, like Race Dental, for example, biggest in Australia, and some of the other labs who are very experienced in they can share advice about what they've had experience similar to other patients perhaps. And fourthly, I suppose the take home is when in doubt, perhaps seek a specialist opinion before you commit to replacing the restoration. And again, I think the ones I showed, which I deliberately chose the one with the swollen lips, that was a very much a quick time response. And within 24 hours, the lips blew up. I think it's a fair call to say that's a true allergy. And in that case, you would address the cause straight away. But a lot of these changes that we see in the mouth are very chronic over a long period of time. And the problem we have is association with the materials and recognising that it might not be the dental material at all, it could be something else. And in those cases, again, just seeking advice, having a biopsy done perhaps of the tissue. These are tools that you can refer to. These are tools we can use to come to a conclusion. And it's okay with one crown, but you can imagine doing a full mouth rehab and then suddenly the patient's allergic to the material. It's real tiger country to actually get a proper outcome. And so always seeking the professional advice is what I gathered from my preparation of this presentation stood out.
Mate, I thank you so much. I've learned a lot. I was unaware of anything such as an amalgam tattoo as well. So I'll be looking into that. I'm hoping that they don't catch on. The benefit of using Australian-made lab, obviously, is we're heavily governed by the TGA and biocompatibility of materials. If you need to know any information, we're happy to provide the composition of all of our products and the TGA regulations. You can be rest assured that we're using nothing but approved materials. But Michael, I do thank you for your time. I know you've got a busy day ahead of you, so I will let you go. We do have a couple more presentations or webinars coming up from you, and we're looking forward to seeing you soon for episodes 32 and 3.
Thank you very much.
All right, thank you very much, everyone. We'll see you all soon. Thank you very much.
Thank you. Bye.
Bye-bye.